Good morning. My name is Dr. Raja Adnan Ahmed, and I am a consultant psychiatrist working in UK. And with me this morning is Dr. Javaria Faiz, who is IMG from Pakistan, who came to UK in 2017. And the reason I am interviewing her this morning is because she is a core surgical trainee, and a lot of IMGs ask me, what is the prospects of surgical training in UK? A lot of people are interested in surgery, but they get these negative messages that IMGs don't get surgery, or IMGs don't have chance in that specialty. So I thought it'd be good to actually meet an IMG who's actually done it successfully. Javaria started her core surgical training in August 2020, and she's also written a blog about it and share her experience so other people can get inspired and get some guidance. So first of all, Javaria, thank you very much for joining me and doing this. I think you will be helping a lot of people by sharing your experience.
I hope so. Fingers crossed. Thank you for having me.
So first thing I need to ask you around is, what is your journey has been in UK so far?
So starting from my graduation, I graduated in March 2016. I went to a medical school based in Karachi, Pakistan. Soon after, I did my one-year internship, which all of these guys would know is a prerequisite to getting a full GMC registration and license to practice. I did my PLEB 1 and IELTS within that 1 year of internship, and 1 week soon after my house job ended, I was here in the UK and prepared for my PLEB 2 exams and took them as well. At the same time, I applied for jobs and then started my first job in the UK in September 2017. So my first job, of course, it was a non-training grade, it was a trust grade. Some people would call it a junior clinical fellow or a FY2 equivalent post, and that was in London King's College Hospital. It was purely surgical based, where I went through rotations of upper GI, colorectal, and then some acute trauma. I was in that job for around 10 months. So after that, I applied for FY2 standalone program, and then thereafter I applied for my CST post, which I'm currently in. So, I mean, one thing that I would like to emphasize about is you have to be in a non-training course when you come as an international medical graduate to improve your portfolio. Also, it's a good idea for your first good, I would say 4 to 6 months, to get used to the system, be a safe doctor, get to know the system in and out. So you're at the same level as any graduate from this country. And then think about jumping into any training post. Do not rush into any training post. That's my first advice. Otherwise, you will find yourself in some hotspots where you don't want to be. So 4 months into my first non-training post, of course, it was, so I started my job in September 2017, and the following year in November, as you would say, all the ST1 level applications start. So I went through Oriel and everything. So starting from the eligibility criteria, when I had a look at it, I knew I'm not a British resident, I don't have any ILR. So it automatically ticks me off even the eligibility criteria. It's no meaning filling an extensive application form and then getting a rejection saying you're not even eligible to apply or come for an interview, let alone going through the self-assessment, scoring, portfolio, and everything. So I put a little bit thought into it, had another look into the eligibility criteria, and down the page, there was one criteria where it said you would be exempt if you are in a training post that's been sponsored by Health Education England or Health Education Wales or Scotland or Ireland equivalent. So there were several options into it. I can apply next year, polish my portfolio, and in the meanwhile, I can just try to enter any training post. So there would be 2 clear options at this point for me. I can either apply for any ST1 equivalent, like a GPS training, and then switch my training pathways the next year, or apply for like a CMT1 post in medicine, or the same goes for psychiatry, and then switch. The problem in that I saw was being in another specialty, which first you have no interest in, first thing first. also, it comes with challenges. Once you are into a specialty training, they would automatically expect certain competencies from you, like taking your exams, preparing for your ST2 year and stuff like that, which comes with a lot of challenges, thinking if you are already, you already want to switch your specialties. Although it thoroughly depends on your clinical or educational supervisor, if they're happy with it. Some people will let you go. People change specialties a lot of the times. Some people frown about it. So I think that was one of the things I didn't like. I didn't want it to be in another specialty, which I'm not interested in. So by the end of my first trust grade job, I sat down with my educational supervisor, and she was very much happy to sign off my FY2 equivalent form, which nowadays we call CREST form. But I was already thinking about being in a training post, and at that point, I said to myself, let's take a step back. She had already signed my competencies, handed me over, but she said, if you want to apply for an FY2 standalone post, then do not use this. Because if I say you are competent, FY2 competent, you cannot apply for an FY2 standalone post. So for me, within myself, I knew I am F2 competent, but just to get ahead with core surgical training and everything, and be exempt from RLMT, I took a step back. So it's roundabout, we are speaking February 2018 when I applied for FY2 standalone post. I went to the interview. By that time, I had a QIP project. I started a research project. I had I had done my ALS by that point as well, which is one of the mandatory criteria anyway for applying for an FY2 standalone program. And I did all the core competencies that an F1 would do in this country, like being able to prescribe medications and intramuscular injections and stuff like that. I think there are around 10 to 12 competencies. I did them anyway, even that I knew within myself that I had done all these things in my home country. So just a little bit of paperwork and everything. Went for my interview in March 2018 for FY2 standalone. And then, well, one of the things with FY2 standalone is if you clear the interview, they will give you a window of preferencing and ask you where do you want to be. Now, these are just the decluttered leftover posts from the F1 and F2 recruitment, which usually happens for the final year medical students. So you don't have much of a choice what to select. There were only a couple of London posts at that time. So, and then a few surrounding areas. So I just started from like within London and going around the radius, preferencing my posts. Of course, there were a few posts in London and my ranking was good. So I sat down with my educational supervisor again, went through all the preferencing and asked her, where do I stay? And then at that point, it was just a matter of either compromising on the location or just going somewhere else doing the post that I would like. So she went through all of my rotations at that point, including my one-year internship back in my home country. And she said, well, from the rotations that I see, I didn't have any ITU or in like critical care unit rotation. I didn't have any experience of GP at that point. And she said, what else would you like to do? These are the two things that I would like you to see before going ahead to core surgical training. You need to have an ITU rotation because it's good for surgical trainees anyway. Maybe have a look at GP, go with an open mind and see if that suits you because it's a good work-life balance. The third one that I selected was doing a trauma orthopedic rotation. Yeah, I know it sounds a little bit crazy for a girl, but then it's something, I think it's basic and it would be helpful anyway. So I had my choices of rotations already. The nearest location that I can found with those rotations and I was confident of was a small town just around 50 to 60 miles east of London, in a small town called Colchester. So I got my post there, I moved there. It was pretty much convenient to go to London every weekend, which was okay. I had the rotations of my choice, saw the GP, didn't like it, crossed it off, went to ITU, brilliant rotation, but anesthetics, not for me again. So moved into TNO, thoroughly enjoyed TNO again. So once again, it was a tick mark that, yes, I need hands-on, I'm good at invasive procedures, and I'm a prospective core surgical training. I applied for CST that year because I was in F2 standalone program and I was exempt from RLMT. At that time, it was a phase where there was a little bit rumors on the IMG group, people saying, oh, if you are in an FY2 standalone program, probably you're exempt from RLMP and you can go into core surgical training. So it was a phase where there was no evidence of it, and probably I was among one of the few people who just took a plunge and went through that route. So inside me, when they invited me for coming for an interview, I knew it worked. But at that time, until I had the post in my hand and they say, okay, this is your core surgical training post, we're happy to have you in the following deanery, I wasn't in a position to publish anything or write a blog about it or anything. If you know what I mean, you need to have evidence of claiming anything. Somehow I didn't get into core surgical training that year. It wasn't because of, so the point that I want to make here is, yes, if you are in FY2 standalone program, you're exempt from RLMT, you will get an interview invite and you will get a post. That's nothing. The reason I didn't get a post was because my interview didn't went well in one of the stations that year. And it was just a misfortune, I would say. It was nothing regarding my portfolio or anything. So looking back from the time of my application for FY2 standalone, sorry, for CST, and my first job in England, it was roughly around, I can say, 14 months. And I was already scoring the maximum I can on my portfolio. So for people asking me, how much time do you need to prepare for your portfolio, or it's a 2-year, 3-year job? No, it isn't. You can do it. You can do it well within 1 year, counting from your first non-training post. I've hardly done anything since when I first applied to CST that year when I didn't get in, and the following year when I reapplied and I got in. I've hardly done anything. If I remember correctly, it's only one poster presentation that I had submitted, and one of the conferences invited me, and I was bored out of death. And I said, well, I have submitted, I have presented it already. Let's just go meet some new people and re-present it, and that was it. So yes, you can do it. So now the question is, what did I do when the first time I applied during my FY2 standalone for CST? And I didn't got in, and after that. So taking into consideration the 18-month rule here, which most of the people know, if you have experience of 18 months in surgical training, you can't apply for CST because automatically that would regard you as a much specialized training, and then after that you just apply for ST3 level. So for me to take a decision by the time I was finishing my FY2 standalone, so your foundation period doesn't count in it. Anything else apart from that does count. So my first job, which was like 10 months, if I apply for another surgical job, whether it's non-training or whatever it is, it would count towards those 18 months. And of course, considering you have to, I mean, for IMGs, you have to apply for visas, pay the hefty fees. It wasn't worth me applying for another non-training surgical job at that point, applying for an application, being there for another 6 months or so, and then coming out of that job and then going into medicine. And it's around the same time where COVID kicked in. So I had to make a balanced decision on what I do. Now, finishing my FY2 standalone program, while I was thinking about this, what I did was, I just remained in the same hospital I was in, because my FY2 standalone, it finished in July, at the end of July, and then from August, there was a new term starting. So the jobs in UK, they usually start from August. It's not like Pakistan or India where you just start the new year from January. So what I did was I remained in the same hospital. I just minimized a few obstacles from my way, which was if I change hospitals or location, it means I have to move houses. And considering that the next application round would be in November the same year, so it only gives me like August, September, October, November, 3 months. It's very hard to go into a new hospital, being adjusting in it, moving your houses, it's just some extra obstacles that you don't want to if you're reapplying for a training post. So I just remained in the same hospital. I was happy there. At the same time, COVID kicked in, and I ended up doing, it's not only me, all of my surgical counterparts who were in training at CT level, even in post-surgical training, even they ended up doing a lot more medicine than surgery that year. So my experience after the FY2 standalone was, I had a renal rotation, I had a cardiology rotation, and then I was sent off to redeploy to care of the elderly. Now, me being a surgical training, telling you I have a background of medicine experience. So when I started my core surgical training and I look back at all the rotations I had, I have equivalent half and half surgical and medicine experience. So, I mean, I would say being in the UK, I have been through a GP rotation, a lot of medicine, ITU and everything, and I have ruled out every specialty. If it's not for me, it's not for me. Most of the, one of the commonest mistake that every IMG makes is they come here, they do a trust grade job, and they rush into training. And then they don't like it a few years down the road, and they're completely burned out. So I would say do not rush into training in this country. You will always require more experience. I've seen specialty registrars who are like ST4, ST5, they freeze their training. They burn out, they go do some volunteer work, they go to like war zones, MSF, you might have heard of those things. Some people just take out a year for traveling. I mean, there's no insult in it. Some people just freeze their training, go into academic pathways, they go into America, do a fellowship, they go into Australia, Canada, everywhere, even after post-CCT, before becoming a consultant. So, I mean, if you are in medicine, you will always crave for more experience. So there's no point rushing your training or rushing into training before you know what you actually want. And then, anyway, the following year, I reapplied for CST. My interview went with flying colors. My ranking was very high at that point. I just had to make a decision where do I stay. So currently I'm in Wales. That would be another factor for people saying, oh, well, I came into this country and I came into this country thinking that I would be in a big city like Birmingham, London, Manchester. That was my dream and stuff like that. Well, in this country, I would say every city has equal facilities. It's not back like in Pakistan where I am in like some very northern area or very southern area where there are no facilities or anything. You can get a good amount of facilities for living, for everything. You can get from one city to another city very easily. So the things that you should consider choosing any training post is, where do you want to see yourself when you come out of this training program? It's not only entering, it's exiting. And when you're exiting this training, whether it's 2 years or 3 years, getting into higher specialty, where do you want to see yourself in the long run, like as a consultant? So my ranking was very good. I could have prioritized London. So the specialty I wanted to be in ST3, I'm not going to say anything about it right now. That's a thing for another day, when I get to training number for ST3. I had to pre-plan which rotations I want now. Whether I want a themed specialty training or an uncoupled CST post, or what was it. And that combining along with my personal circumstances, I chose a very nice hospital in Wales, which is offering me all the training and rotations I want at this point. So for all the people who are hearing me now, if you think I'm in Wales, I came from Pakistan, okay, what is she doing? Why is she in Wales? We wouldn't get training number anywhere. I would say if your ranking is good, you will get a training post anywhere. If I would have ranked London as my first choice, I can guarantee you I would have gotten it. London was nowhere among my first choices. You would be very amazed to hear from me that Wales was one of my top 3 choices, the current hospital I am in, and I've got one of my first 3 choices, which is amazing, I would say. So it all depends on what you choose and what everyone else's journey is. I mean, it's every individual's choice what they prefer and what they're looking forward to. There's no point sticking onto a location, craving for like having a lavish life and then ending up nowhere in your career. Both your personal and career life, they go parallel to each other. And if you're not happy in one, it's likely you're not going to be happy in the second one. So for every choice that you make and preference you put into, um, sit with your friends, sit with your family, sit with your supervisors, have an input from everyone. At the end, the decision is yours, but I would say make it wise, whatever, and make it worth your time. For every IMG that comes into this country, of course, that you are sacrificing on a lot of stuff. You have all been through a lot of hard work and everything. Getting into training is not easy. It's a lot of money, time, effort. It's not impossible. It is hard work, but I would say it's not impossible. Stop listening to those people. You will meet a lot of people along your career who would tell you, okay, well, I wanted to be a surgical training or I wanted to be a psychiatric training, but now I'm just an ED registrar or an ED locum consultant or something like that. Don't waste your time. Go to GP. It's good money and this and that. Don't listen. It's okay. You don't have to reply to them. I mean, listen to them, but just don't. It's up to you whether to get it into your head or not. Maybe they're saying it out of love for you or the hardships that they have been through, and they would say, oh, well, I went through this journey and I've ended up like this. I would hate to see a young boy or girl, an IMG, come to this country and go through the same thing and then reach nowhere. But don't take them as a reference for yourself, I would say. Just keep a little bit faith in yourself. I think you can get there, whether it's any specialty or any training. Nowadays, it's become a little bit more easier, thinking the RLMT has been scrapped out, and it's probably because of Brexit and everything, because they think maybe the European people will go out of UK for training elsewhere, and they would end up having deficiencies here in training numbers. But again, I mean, things keep changing year to year. So yes, you have a window, you have a good window. RLMT has been scrapped out. I would say take it to your advantage. And make the most out of it. Rules don't stay the same forever. You need to keep a close eye on the government website and ORIEL. They might change the next year or the next year when things are a bit more stable, COVID-wise or Brexit-wise. But everyone has a good opportunity now. So, and it's not like before. I mean, when I came to UK, there were hardly any resources on Facebook that I could read about PLAB or anything. I think Dr. Umar was one of the first ones I saw, and I would just study his blog like religiously, not making sure I'm not missing a step or anything. And then Dr. Nasir came at some point, which was amazing as well. So I mean, we have a lot more people now. So we have Raja. Yeah, I'm a small piece in the system as well. And then there are a lot of other bloggers as well. So there are a lot more resources now for people, and they're free resources. You don't need to go and subscribe to a course or pay a hefty fees for somebody counseling you. Just go through all these blogs and you will find a way how to get into training. The rest is just up to someone, how much time and effort they want to put into. Yeah.
Thank you for sharing your experience. I just wanted to say that again, that the RLMT you mentioned, the resident labor market test, does not apply anymore. So the IMGs can directly now apply to the surgical training.
Yeah.
In the past, we have to sort of find ways to bypass that. That was more difficult. I think you did it in a more difficult times when you got your core surgical training. That's the second thing I just wanted to mention was, I think you have raised some very good point. One of the things you said, that not to rush in training and actually take, sometimes it's good to take a step back and sort of look around for other specialties, experience them as well, and see if they are for you or not. That is I think good advice. Then you said around that by spending time in a non-training post, although they're called non-training posts, but you should have opportunities to actually build your portfolio working there.
Yeah.
Sure. So, you know, when you are going for a training post, then you will have those things which they will expect from a British graduate on your CV. So your CV will appear, your portfolio will appear much more attractive to the recruiting teams. And I think the other thing you said about the research is very important, that you do your research around whichever specialty you're applying for. As you said, the recruitment rounds change every year. There are new rules or new methods, the way they test the applicants. So it's also important to sort of look every year that what are the changes coming through, and how can you maximize your chances. The one thing I wanted to ask you, I think you mentioned around going to CST and process and the portfolio. What was it like practically, when you applied for it? I know this year it might be different, but when you applied for it, what was it like? How many stations were there in the interviews, and how did it go?
So the first time when I came to this country, like when I applied for the non-training job, and that year when I realized my eligibility criteria, I wasn't eligible for it. Looking into that first application that I ever saw for the portfolio scoring, the whole scoring was out of 36. It was a more simplified version of what we have now. So it's the same sort of categories, but if I take one example, for example, having a quality improvement project, if you have done a full cycled and re-audited a full like QIP project, and you have presented it locally, at that time that was holding like the maximum marks. The following year when I applied, when I was in a FY2 standalone, I applied first time for the CST. They had inflated the whole portfolio, so initially the marks were out of 36, and that year the marks were out of 72, which is double the amount. What they did was, it was the same categories, but they just inflated into, for example, taking back that example of a QIP project. So this time it would be, if you have presented it locally, it would hold less marks. And then it would hold more marks if you have presented it in a regional meeting, and then more marks if you have presented it in a national or international meeting. So they sort of inflated the portfolio. Coming to this year, so before we started the recording and everything, I just downloaded the core surgical portfolio scoring for this year. And there are very minimal changes that they have made this year. It's the same scoring, apart from just messing up a little bit with your commitment to surgical specialty and making one or two things more permanent, rather than giving you a free chance of showing like your commitment to specialty. So I will come into the detailed scoring of the portfolio and everything a bit later in our talk, but yeah, so the interview itself, you usually have 3 stations. So one is the portfolio, which they would the minute you enter, they would take it away from you. The examiners will have a good 10 minutes look at it before you enter into your portfolio station. They would have compared it with your self-assessment scoring randomly, just to make sure that you haven't overscored or underscored yourself. And when you go into that station, they give you a free chance of, so I would say it depends on the type of interviewer you have. So one of the types of, so there would be 2 people anyway. One of the interviewers will just go through again with your full self-assessment scoring and say, okay, so you have said you have done this, you have done this, you have done this, and they'll flip your portfolio, flip your portfolio, flip your portfolio, and completely exhaust you. They will just pick up for example, if in research you have claimed for a certain number of researches and they don't think that that's the relevant marks, you have either underscored or overscored yourself, they'll just ask you an open-ended question, and then it's completely up to you to justify yourself. Why have you scored that certain amount of score? And if you are able to convince them, they'll give it to you. If you are not able to convince them, you lose those marks. So it's just more about checking the evidences you put in your portfolio, and they're just making sure everything is transparent. They give you a good chance. It's nothing, don't take it personally on yourself. At a CST level, they know you are coming from a foundation program, and there's very limited you can do in your foundation program. So they're not being hard on yourself or anything. Don't take it personal. It's just they're giving you a chance to claim those scores, and I think there are brownie points. If you can give them enough evidence, that's fine. If you can't, don't take it in yourself. Just move on to the next station. The second type of interviewer, which you might find in your portfolio station, is not the one who just flips and flips. They would completely blind trust you, and they would say, okay, fine, if this person has scored themselves, let it be. What they judge you by picking out the most interesting project in your portfolio. So for example, they would just point out a presentation or a QIP or project or some volunteer work that you have done, let's just say, and they would say, okay, so tell us more about it. This is very interesting. And then that's an open pitch. You just go on for 10 minutes explaining to them what did you do, what the project was about, why did you did it, how did you came up with the idea, what was the benefit of it, what were the challenges involved. And those are sort of like the more senior interviewers who actually enjoy meeting different types of people and make the interview a bit more like interesting, rather than, there's several candidates throughout the day, they just can't go literally through like portfolios for everyone. So you might end up having two types of interviewers there. It completely depends on your luck. So moving away from the portfolio station, you have another station, a second station, which is the clinical scenario station. Now, the clinical scenario station, they're 5 minutes each scenario. One of the scenarios, it will already be stuck on the wall before you enter into the cubicle. You have a good 2 minutes to read through the scenario. It will usually be either an A&E referral, or it will be a trauma patient. So without going into the specifics of what I got, because I think we are not allowed to talk about what scenarios they usually give us. But it's usually it's an acute scenario, either an A&E referral or a trauma patient, which means you have to go and see that patient like in real life or something. So you already know the scenario, you have went through in your mind what I'm going to speak about it and this and that. So you just jump in, go there, handshake, introduce yourself, sit down, and then you just go through a scenario. It completely depends on the interviewer again. There might be just a quiet one, which are just sitting mask face like this, and you just go on for 5 minutes and they don't even ask you a tiny bit of question. Or if the best idea or the tip that I can give you is, when you have gone through your A, B, C, D and everything, and management and investigation, initial management and investigation, just try to give them a pause, like a few seconds pause, 3 to 5 seconds, and see if they come up with a question. If they come up with a question, it's even more brilliant for you, because you know what they're looking for, and if you answer them, you have scored top marks there. So that would be the first scenario. The second scenario is usually a ward-based scenario, which is more like a nurse calls you and tell you, okay, there's an acutely unwell surgical patient on the ward, and what you do. So I think the basic, it's not something that we don't do. It's something that we do as house officers and senior house officers every day. A nurse calls you, there's a sick patient, what do? You just introduce yourself, take the handover via an SBAR approach, which is like situation background assessment recommendation. And is there something in the meanwhile you want them to do while you arrive to the ward? So everything is there, like taking bloods, or they can put in IV fluids or everything. Usually it's going to be like a seriously like a crash call, like patient using 8 or 9, and then you just make your way to the ward and just assess that patient. So it can be an acutely unwell surgical patient. The most common scenarios, because it's a surgical specialty we are talking about, would be a post-op patient, which had just come out of surgery a few hours later, or it's maybe a few days down post-op, and they've ended up having some complications. So it's just about your management. What do you do? And so once you go through your ABCD and everything, what the things they're looking for is for you to be a safe doctor. They know you're excited about being a CT1 and jumping into CST, but want safe doctors. The transition between an F2 and CT1, again, it's easier than from CT2 to an ST3, because you're a registrar, more responsibility, but still it's not easier, especially if you don't have an F3 year in between. So just forming your differential diagnosis, and then calling your registrar or escalating it to the consultant and seeing if the patient needs to go back to theater or what is it. So all the way down to the interview, they're looking whether you're escalating things, whether you're a safe surgeon or not, you know what you are doing. And most importantly, they want a doctor that they know the NHS system inside and out. And they will make your life, some of the examiners that are sadist anyway, they will make your life a bit miserable by saying, okay, the registrar is not answering, the consultant is not answering, what do you do next? And then you think about, okay, fine, I can't find anyone. What are my options here? Do I call the bed manager? They find someone for me. Do I call the lead of the department? And things just through the normal escalation pathway goes on. So those are sort of clinical scenarios, which are one like ward-based and the other like more acute patient that they give you. The second scenario that they give you is just like face-to-face. They will throw the scenario on you, and then you just think, so you don't have much time thinking about it. So I would say the first scenario that you are entering into, you have a good 2 minutes, and you can certainly score more marks rather than the second scenario. But again, the second scenario is just a ward-based, you do day to day, every day. So that's fine as well. And some of the interviewers, as I said earlier as well, they will be quiet. They wouldn't even say a thing or ask you a question. And you would come out of the interview completely blank, thinking, oh, well, did I messed it up? Did I perform good? But then it's okay as well. I mean, the interviewers are trained that way. They're not allowed to give you any expression, whether you have done well or done bad or anything. You would often find there's a third interviewer sitting in the room watching these two to make sure there's a fair assessment and there's nothing out of the way. You will also find a lay representative just wandering outside, having a chat with you, making you feel easy, asking you if you need water, or at the end of the interview, if you're happy with your interview or something went out of the way, if you think your assessment wasn't fair or anything, or you even have like, it can happen in interviews where there are a lot of candidates where they think they have been a victim of racism, or they think their interview didn't, whatever it is. I would say if you have any concern, just speak to the lay representative. I have seen people who have complained to the lay representative and they've been offered a second interview session on the same day. They have a circuit panel sitting separately. That panel doesn't know you already had one interview. The lay representative will just make you go through another interview just so you have another chance of a fair assessment. So the first one don't know on the day of the interview what happened. The second one don't know. It's just a fair assessment, a transition, another chance. So some of the people, they would say, I've seen a lot of IMGs feel that way for one or another reason whatsoever. If at all you think during the interview day there is an element of that, I would say most of the people do not know that. Once they come out of the building, there's nothing that can be done. So everything you have to do, you have to report it within the building, and then you just go through another panel, have another interview, and those are the marks that count. The feedback of the interviewers and everything come later on. It's their shit they have to deal with. So I would say that's one thing I wanted to say. I met a very interesting person when I went to one of the interview courses, and she was from Black African origin. I didn't know this as well because I've never been through a victim of racism or anything in the interview. So she told me she went through a whole circuit of interview, and I found that very interesting. I'm like, how so? And then she explained that, yeah, they can take another interview from me the same day. So I've often seen concerns from IMGs on platforms where they think it's not fair and square. If you think it's not fair and square, there is an option. So that's certainly one thing I would want to add. The third station, now moving from the clinical, so we have done the portfolio clinical, and then you have a management station. Management station, very interesting. They would send out an email before the interview date telling you there's a topic for presentation, and most commonly that's usually a leadership presentation. So you already have the topic before the interview. Those are brownie points again, I would say. Just pick up something that you have done good leadership in, and you just prepare. It's usually a 3-minute speech. For this specific station, I would say you need to write it out. You need to think hard on it. You need to write it out on a paper, word pad, whatever it is. And what I did was I sat with the core surgical trainees in my same hospital. Not even with the core surgical trainees. I was in a TNO rotation at that point. And I even sat down with my clinical supervisor, who is like a TNO consultant. I mean, getting a TNO consultant to sit with you for an interview session, it's very hard, but you can do it, like chase their secretaries, make an appointment with them, whatever it requires. These people, they usually sit in interviews. A lot of the interviews, they know what they're looking for. Just run it past them. You need to time yourself. You only have 3 minutes for the leadership station, and you need to finish everything within 3 minutes. Now, it shouldn't be too much robotic, like you go there with a big speech and you're like, I've done, starting from the day you were born till now, and you're like, I've done this leadership, that leadership, that leadership. No, it doesn't work that way. So you need to come up with more interesting ideas. If you can say, okay, I've done this in leadership as an open like pitch, and then you just pick out one thing, one interesting leadership thing that you have done, and then you just speak about that one leadership thing. So the rest of the 2 minutes, so 3 minutes you speak, 2 minutes they question you. If you've talked about one specific thing, they're likely to ask you questions on that topic. So you're generating your own questions, or I can say, so if you talk about the wrong thing, then it's like you're digging your own grave, if you know where I'm coming from. So yeah, it's a good chance that you know what the examiner is going to ask you next in those 2 minutes. So you talk about that in 3 minutes, and then they cross-question you for 2 minutes, and if they're satisfied, that's fine. That's the end of your 5 minutes leadership. Within that same station of management and leadership, so you have 5 minutes for this presentation. I think for the last so many years that I have known, it's been the same topic, leadership. It hasn't changed, and everyone knows about this. I don't know if it's going to change or not, but it's likely you will receive the topic if it has changed beforehand anyway. The second 5 minutes are for management. So it would be, it can be any management scenario. So, I mean, all the IMGs that have come to the UK, even been into trust grade jobs, you would have been advised at some point to read an interview book or something, and there are common management scenarios that they throw at you. So it can be something like, so for example, you're the day on call SHO or something, and then your night SHO doesn't show up, and how would you manage this circumstances, and you go through like the whole stuff. Or it can be anything, managing, like you don't think the rota is fair and fair, and you think you've been working more hard than your colleagues. How do you manage this? So it's just checking your management skills, because being a surgeon or even a medic is not only about your clinical skills or whatever is in paper on the portfolio. It involves a whole breadth of stuff like management. So the rest of the 5 minutes are just for management, and they see how well you manage it, and how well you discover the scenario in itself, whether you seek help or not. There's a full, so at the end of this session, just remind me, I will talk about 2 books that anyone who's interested in getting into CST, they can go through those 2 books, and those are the most common scenarios. So yeah, so I mean, just to summarize, we have a portfolio 10-minute station, a clinical scenario where you have like 2 scenarios, and then you have a leadership and management, and that's it. So the whole interview itself is around 40 minutes. So 10 minutes for each station, and then you get a 10 minutes like a stay station or a break station, which is it. In some cases, if you are the first one in your circuit, because there are 3 people rotating, you might end up being the one who goes through like portfolio, clinical, or leadership, and then the 10 minutes they're like, okay, your interview's over, just bugger off. So I would say it can end up, and it's not necessarily in the same order. It's not like portfolio first and then clinical scenario and lead, because there are 3 people. So you might end up having the leadership first, and then the portfolio in the middle, and then the clinical scenario in the last, or vice versa, in any combination. One thing that I would like to say here is, if you think at one point in your interview that your interview didn't went well in one station, just leave it. Once you're out of the station, leave everything behind, move on to the next station. There's an equal chance you're going to score much better in the other station. Don't let it ruin your whole interview. Another thing with regards to the interview people thing, so I mean, many of the IMGs, even the non-IMGs, I mean, the people here who haven't been to the CST interview, they think, oh, well, it's portfolio, it's portfolio, it's portfolio, it's portfolio, let's die on portfolio. No, it's not. Portfolio, as I said, I've said so far, there are 3 stations. Each station holds equal marks. If you don't have too much on your portfolio, if you've been invited to an interview, it means you have sufficient on your portfolio. Now move on, don't cry about it. You have other 2 stations, you have a clinical station, you have a whole leadership management station. You can score golden points there. each station hold equal marks. So many people think it's portfolio, and once they're invited into the interview, they're like, oh, somehow I think we have made it. No, that's wrong. You still have a good chance, because you want to score maximum points and then rank the highest, so you get into your themed specialty of choice or the rotation that you want. And that's how your approach should be. So each station score equal marks. Now, why am I saying it again and again? Not a crazy woman or so, might be a little bit, but all the people that have approached me so far through my blog are, tell us about the portfolio, tell us about the portfolio, tell us about the portfolio. I haven't even made a blog about portfolio at this point. I have made a blog about CST interview timeline, how the CST interview itself is the structure, because I want them to think about that first rather than jumping into the portfolio. And it's a very common mistake everyone makes. So you have a fair and square chance. I've seen a lot of people having average marks on portfolio, and then they do brilliantly in the rest of the stations, and they're wonderful trainees now. So yeah, that's just a summary of the day of the interview.
Thank you for sharing that. I think I just wanted to ask you, since the COVID crisis came, a lot of the interview patterns have been changed. A lot of face-to-face interviews were cancelled. Like I know for psychiatry, we don't have any more face-to-face interview for this round at least. Is there any changes to the interview process for the CST, or you don't know much about that at this stage?
So I had gone through the Oriel application this morning just to see if I can provide any input about this. And I mean, comparing it to the round that I applied in, there has certainly been changes. So I think there are two plans in place. So what we were expecting this year is when somebody applied to CST, they would just ask about the self-assessment score on the portfolio, and then they just score you through your portfolio, and they just give you preferences with regards to that. But looks like, from what I have read on the Oriel system, it's not like that. So you're going to self-assess yourself. After you've done your self-assessment scoring, there's going to be a shortlist scoring for whether you're scoring enough on your portfolio to get an invite for the interview. And once you get an invite for the interview, I think they have made another short window period until mid-January, where they ask you to submit your evidence. So, for example, if you have claimed for a KRP project or a research project or poster presentations or anything, they might ask you to upload your whole portfolio online, just so they can cross-check, or they might ask you just random bits and pieces to upload so they can check it. And once they have verified your evidence, they will invite you to a Microsoft Teams interview. And the Microsoft Teams interview is going to be on clinical station and management and leadership station, because they have already verified your portfolio online. So considering COVID-19, they have changed the system a little bit. But there's going to be an interview, I mean, on Microsoft Teams. So, which is again good as well. I mean, you're just sitting at the comfort of your home. It's not like, so you don't have to travel to the place of the interview on the same day. Usually the interviews are all in London. For CST, it's nowhere else. It's not the same as an IMT or CMT. There are usually a lot of posts for medicine training. So there are a lot of centers, but for CST, all of them has happened so far for the last 5 or 10 years or so that I know is in London. So you don't have to travel, first thing first, which is good. So save some money and time and stress. And it's just, you dress up nicely and present yourself through Microsoft Teams. And so, yeah, I think that's been the slightest change.
I think the other question that a lot of IMGs would be interested in, if somebody is already thinking about core surgical training and they might be in their home countries right now doing PLAB, or they might be working on a non-training post right now in the UK, what sort of things they should be doing? You mentioned the self-scoring system, so to get shortlisted or to get relatively comfortable on the portfolio marks, what are the things they should be doing?
So I think there are a few things here. I would say everyone has a good internet connection and laptop. Just go into the Oriel system. It doesn't cost anything. Just register yourself, make an ID, go inside any specialty, any application that you want, click on it, and it's usually associated with some hyperlinks and documents, and you would usually find a good handbook through the whole, where they have faced like the whole interview system and what the requirements are, and there's usually a self-assessment scoring document for portfolio. You can download it beforehand, even if you're a medical student, you have an oral ID or an F1 or F2, want to be in a prospective surgical medicine or psychiatric training or anywhere. You can download it, look at the portfolio scoring system, and see how many courses you required, how many projects you required, how many presentations you require, how many cases should be on your logbook and everything. And once you know what is required, it's easier, then you can plan it and you can do along the way. Don't wait for the application deadline. People often wait for the application deadline, they open it, and then they realize, oh, there's so much to do, now I can't do it. Well, I would say a bit of pre-planning goes along the way. When I came first year in my trust rate job, first 4 months and everything, it just took me like adjusting to the NHS system, but I already had the scoring portfolio sheet in my hand. And I just planned everything along with it. My aim was not only achieving my F2 equivalent or getting into standalone. I was already preparing through the core surgical training line, picking up projects and everything which could get me into the training post. So I would say download those things. People often end up wasting time like texting each other on Facebook Messenger or something, or just waiting for the other person to reply back to them. Oriel, Oriel is a thing, it's a website. Go in there, you can find anything. Especially during this time, all the applications would have been open. So if there is someone watching us who's an F2, wants to take an F3 year and then want to apply, or is an F1 or even a 5th year or 4th year medical student wants to come to the UK, you can access Oriel website. Just make a registration ID, go there. I'm not saying fill in the application form and apply for the application. You don't have to. Everything is available for download. So just download those things and see what you can do. So I will go in detail with you along the whole portfolio thing and tell you what the scoring system is about. I think I want to say about one more thing, but I'm slightly forgetting. So yeah, what has happened with the RLMT being changing beforehand, because the RLMT was an issue, and that would subtract most of the international medical graduates from even applying for any training course in a very competitive specialty. And usually what would happen is all the British graduates or the European graduates, they would 100% get invited into the interview. So for core surgical training, they usually have a space of interviewing 1,300 candidates, and the posts are usually 500 plus. They're less than 600, so it's 550 or something, but and the competition ratio is 2.5:1. So, but the capacity is only interviewing 1,300 candidates. So what has happened with RLMP, because now the IMGs can step in because they've crossed the eligibility criteria and they can apply in as well. Of course, there are thousands and thousands of people competing for those posts because they are on the same front line. What they have done is they have changed the criteria from the eligibility criteria based on the portfolio self-assessment score. So let's say, for example, just a random number, don't get scared if somebody's listening to me. So let's say 5,000 candidates have applied for core surgical training this year. They cannot by any means accommodate and interview all those 5,000 people. So what is now happening is they would see what the top 1,300 candidates are scoring on the self-assessment, and they would set a bar, like this is the minimum portfolio score requirement. And then you get an interview. If you're in the top 1,300, you will get an interview invite. Now people would be thinking, what is that magic number or magic score that I need to hit in order to get an interview invite? Well, we don't know about it. It depends on every year, the cohort of people who are applying for the application and how much maximum everyone's portfolio scoring is, and what the top 1,300 candidates are scoring and what the minimum set point is. So if you get an interview invite, it means you are in a pretty good position and you would be competing in the interview against some very hard candidates. Now, looking into last year, normally all the F2 candidates that were international medical graduates would be hoping to get an interview in white because there was RMT in place before. So the bar was just a little bit low. I have seen a lot of brilliant F2 candidates who had good average portfolios. They did not even get an interview in white for CST. And they couldn't understand what's happening. But of course, the IMGs have stepped in after the RMT has been scrapped out. So the bar is very high to get an interview in white. So if you have got an interview in white, it means you're in pretty good shape and position. All you have to do is perform well on the day of the interview. So that's something that have changed. A few weeks ago, somebody popped in this question and said, okay, so what was the minimum set point for getting invited to an interview? I'm like, I don't know. I went back to my oral application scoring for last year when I applied. And usually they would say shortlisted score and they would give the score. But last year they just said shortlisted, published, and nothing, no number. So it changed. It depends on a lot of factors every year, and it's a little bit changed since. So it looks like we have IMGs who have good portfolios, and they are getting interview in white as compared to the other British graduates or who are currently in the foundation training program and everything. So I would say, I mean, just a bit reassuring that there are wonderful candidates out there who are already working on their portfolios. And I know it was a bit unfortunate from before this that RNMT was in place, but since it's been scrapped out, just take advantage out of it.
And coming back to the scoring system, are you going to advise something around how do they score well based on the CS scoring system?
Yeah, so there are different categories on it. Sorry, I have it open on my other laptop, so if I'm looking the other way, don't mind it. So starting from the first category that I see is where they ask you about postgraduate degrees, qualifications, and any additional degrees. The maximum you can score this year in this category are 4 points. And those 4 points are for PhD, or if you have done an MD. I mean, don't get apprehensive about it. Not everyone has PhD or MD. Some of us are very fresh graduates, very much in line with our medical career, not even taken a gap out. So if somebody has done a PhD or MD, it means they are 4 years, or let's say a good 5 years, much elder than you, and they would be expecting much more from them in terms of projects rather than you. So if you don't have PhD, MD, I didn't have PhD, MD, it's okay. Let alone, I didn't even have a master's. You can still score something in this section if you have an intercalated BSc or BA. Most of the UK graduates, they do an intercalated BSc or BA here. Unfortunately, the culture, I mean, I don't know about other countries, but in Pakistan, it's not so encouraging. I've hardly found anyone. It's not a difficult thing to do. You can do it along with your medical school. If you're a medical student listening to us still out there in a developing country doing your medical school, you can still do an intercalated BSc. You don't have to take time out of your medicine school. All you do is apply for it, put your application in. And it's just like a private exam, which you do in some extra subjects. You can do it in English, you can do it in maths, you can do it in like zoology, botany, whatever you like. You can do it. And yes, you can score points, not too much. I think there are 2 points, but if you can score 2 out of 4, that's fine. I mean, I was scoring 0 in this section. I don't have an intercalated BSc or anything. So, I mean, for me at that point when I was applying, stressing on this section was not worth my time. I cannot go back in time and pray to God that some angel would have appeared and told me, oh, well, Javaria, you need to do BSc. I was among the top cohort in my medicine school, top 10 candidates. But I didn't know about it, and it's fine because you're coming from a different system, a different culture. So I would say if you don't have it, make your peace with it. It's not the end of the world. Moving on to the next section, we have a section where it asks you for prizes and awards. It's a section where you can score at least the second highest. So the top scores are, the top score is 8. And 8 is for if you have been awarded a national prize related to medicine. So, I mean, if someone has been an undergraduate and have been awarded this, well done. I would say I didn't have it personally. I was scoring the second highest marks in this section, and that are 6 points. And the 6 points are if you have distinctions or merits. Distinctions and merits in your undergraduate school, it means if you have topped a subject, and even if you're not the topper of the subject, at least you have scored that much that at least 10 top % of your class would have had it. So it's like a distinction. So if you have any distinction, go back to your medical school, ask them what this distinction was based on. Is this distinction based on because I was scoring among the top 20 candidates in that subject, or the top 15%? So for this year, they have set the bar to, it says high achievement award awarded to no more than top 15%. So I would say if you had even one distinction, just put it on there. I had a few distinctions there, luckily. So I would say I was scoring there. But again, if you go down the lane, there are other things. For example, if you have a regional prize or a local prize, you can still score something in there. If you had a scholarship bursary, you can still score 2 points in there. So it is a section, I would say it's not impossible. Of course, you need to be aware during your medical school. Even if you were not aware you are a good candidate, it's highly likely you will have something to score in this section. The third section I can see is the quality improvement or clinical audit one. Now, again, I mean, going back to our medical schools and cultures, I mean, QIP projects and audits, they do not happen that much, but it's not something that you can't do. The minute you come in, you're well settled into the system, you can do a quality improvement project, but you need to close the quality improvement project. Now, I mean, it's very easy, and I've found a lot of people who don't know the meaning of closing a QIP project. So they do a QIP project and they present it, and they think that's it, that's a closed cycle. No, a closed cycle means you have presented it, you have implemented the change now, and then you have re-audited it to see whether the changes you made, it made any difference or not. It doesn't matter whether it made a difference or not. Because you have re-audited it, you can say it's a complete cycle. So you need to have a complete cycle. Don't leave projects midway. Now, again, I mean, one thing that I've learned from my own experience, I usually like to do projects which are, they would be big projects I'm very enthusiastic about, which are really the kind of projects you want to make a difference from. But you need to be, it's all, the portfolio scoring is all a game. You need to be practical about it. Take a small project, take a small audit or a QIP, which is easy for you to close, and score top marks in it. It's in this station, I can see it's 11 marks. I was scoring 11 out of 11. And it was a very lengthy project that I did, but I closed. But I can say you can easily do it, even if you have like 3 months or 4 months left for your application. Don't leave it to that. But if someone is listening to us and is in that position, you can still do it. Just do a small project like the VTE assessment, just the pain management of your patients, or antibiotics, or small stuff like that. You can easily close the loops on those projects, and you can score the top maximum points on it. However, there is one thing that they have added onto here, is that you should have had the complete results of a project, QIP project or complete audit, and presented it in at least a regional or national meeting. So I know you would have done the project, someone might have good evidence of it, a letter even from a consultant, but you need to present it. So I would say crack on these QIP projects hands-on. You only need one QIP or one audit. It's not that much. If you have done it, just submit it to some conference, even if it's a crappy conference, a crappy meeting or anything. It doesn't need to be like a hi-fi thing. Just apply to multiple things and get it presented, even if it's a poster presentation. If you have presented it in a regional or national meeting, you can score marks on it. I had a lot of QIP projects, but I had already closed one at my point, and I did present it in a sort of national/international meeting, so I was scoring high on that. If somebody has a closed project and they, however, haven't made it to presenting it in a regional, national, or international meeting, the second category you can score is 9 marks. 9 out of 11 is a lot of marks. the criteria for that is you should have presented it at a local meeting. What is a local meeting? I mean, your local departmental meeting, your M&Ms meeting, your MDT meetings, or maybe the journal club that everyone have, or the grand rounds. You can, those are easily accessible. You can still score 9. So I would say once the project is completed, go present it within the hospital. Next, then take on from there and apply. Like, don't sit, okay, I've applied for this conference, that conference, I'm not getting an acceptance letter. Oh, what am I going to do? I'm not going to score top marks. No, just look at second best next station. If you can present it local department, you're already in a good position. 9 out of 11, you have already secured that. Now move on. Just apply for regional or national meetings. If you can present it within time, you're just going to get those 2 additional marks and you're good to go. The next section is having teaching experience. Again, this is something that we can do. It's not like having like being a teacher for 1 year, qualified teacher or anything. You can sit with your clinical or educational supervisor. All you need to do is design a project that you can run for minimum of 3 months, and you can just do like fortnightly teachings. It doesn't even have to be like every week. Fortnightly teachings within your local trust to your colleagues or junior doctors. Say it's F2s, F1s, medical students, just gather them. The way I did it was with one of my other colleagues. I mean, now it's something that requires a little bit more manpower. Don't take on projects solely on yourself. It's likely it's going to be a teamwork. Just see in your surroundings if there's someone who would be interested in applying for core surgical training or any other training who have the same requirements. I took on a project with one of my other colleagues who was interested in CST as well. So all we did is just make a plain document of what we think we should have teaching on, what we are lacking, and we just made like 8-9 topics. And then every fortnightly we would just book a conference room, whether it didn't matter. I mean, we delivered teaching in the it's funny, in the urology conference room, in the vascular conference room, in the orthopedic because we needed a space. You can go to your postgraduate education department and ask them for a room for presentation. The second thing you would need is just a teacher. So circulate your emails, like give it a good logo and tell, oh, we have designed these teaching projects, and if somebody's interested in teaching like junior doctors or anyone, would you mind telling us the dates or your availabilities? And then see, because people are busy, it's not like you can ask them, can you come on this date, this time? Just be a little bit flexible with them. People will come up. I mean, even registrars, they need this stuff for their own portfolios, like teaching other people. So you would likely find a lot of people, even the senior nurses, like who does the dressings on your ward, they can come and teach a lot of stuff from to you. So we just organize like a lot of teachers and their flexible times, and even if we have like 5 people who would show up into teaching, that would just do the job, because then you can say you have delivered teaching. You can just gather feedback from those students and everything. So if you run it over for 3 months, your supervisor should be happy to sign you a letter and say, okay, you have organized a teaching. So the words that in the portfolio they require is, I have worked with local tutors to design and organize a teaching program, which is a series of sessions, in order to enhance organized teaching for healthcare professionals or medical students. And there are several options. It should be either at a regional level. The thing I did wasn't at a regional level, it was a local hospital. And then it says you have contributed regularly over a period of 3 months or longer. Okay, so there you go. I mean, now because of COVID-19, I would say it's even more easier. You can do it regional, national, just make a Zoom link, ask people to pitch in, and once you have people from like different hospitals or anything, you can easily say, oh, well, it was a regional thing, it was a national thing. It's more easily justified. So we have opportunities now. You can easily score. There are 8 marks in this section. I don't see why anyone shouldn't be having it. Even under, I mean, overwhelming circumstances, if somebody can't make it, there are still some points for where it says, I provided regular teaching for healthcare or medical students. over a period of 3 months. Now, in the UK system, if you are here in a training, it is likely you would be involved in teaching medical students here. So it's very easy to score at least half points in this section, 4 out of 8, which is again a good thing. So I would say aim for like the first top marks, but then if you can't do it, I mean, just stop hustling about it. Look at the second best, the third best section, and see where you can score maximum points. Sometimes people have no personal commitments, they're willing to spend more time on this. Other people might have like families or anything, and they're a little bit more time bound. So be realistic in what you choose and what you choose to do. So that's with regards to teaching. Teaching has 2 sections here. So the one that I just talked about is a teaching experience, where you are like teaching others or doing something. The other section is training in teaching, which means if you are a teacher, I mean, well, up to your certain skills. So one may have certain skills and go and teach people, but with time you need a trainee in himself or herself needs to evolve. So you need to improve on your training methods, and that's what they're looking for here. So I can teach maybe medical students F1s and F2s as a CT1, but then, I mean, what am I doing to progress to ST3 and so I can teach core surgical trainees, or what are my methods and stuff just to improve on that? What they're looking for is if you have a master's or a PG cert or a PG diploma, and that's like top scores, and against it's 4 points. It's something similar to like the PhD section I talked about, first one. I would say make your peace with it. I mean, doing a PG cert or a PG diploma, it costs thousands of pounds. Being an IMG in this country where you have to pay like hefty visa fees and everything, and you're paying for all these courses and everything, I mean, it's not easy. Be realistic about. I didn't have a PG cert and a PG diploma, and that's completely okay. Do I see myself doing this at some point? My honest answer, I mean, the individual, I'll be like, probably no. So, I mean, yeah, if somebody is interested in teaching and they have it, I mean, I would say, yes, go spend on it and do it. But again, it's something that requires time. Sometimes your transition between foundation and CT1, you are a bit time bound. So even if you want to do it, you might start it, but you might not end up completing it. So you have a couple of options here. If you have done a PG cert or a PG diploma in teaching or medical education or something like that, I think you have done one. Well done. And then the other section is if you have substantial training in teaching, which has lasted between 5 to 20 days. So if you had some sort of teaching training, which was more than 5 days, you can score 3 points. I wasn't scoring anything there. The section that I scored in here was if you had any sort of teaching course which was more than 2 days. So we all know here, I think people have talked about on platforms where there are courses like teaching the teachers or training tomorrow trainers. It comes with different names. You can do it for a couple of £100, and if you have done it more than 2 days, that's probably enough for you. Okay, so again, this is a section where I would say if you don't have it, don't hustle about it. Make your peace with it. Just see how much maximum you can score about it. Doing PG certs and PG diplomas, it requires a lot of time, and it's like a lot of money and effort. So if someone has it, I mean, well done. If someone doesn't have it, I would say just look at the second best, the third best, and see to score at least some point. It shouldn't be 0. I mean, by no means it shouldn't be 0. There's even a 1 mark scoring for if somebody has done any online module on teaching. That's very easy to get, and sometimes it's very free. So you can still score 1 point there, or maybe 2-3 points if you do like a 3-day teaching course or something. Now moving on from that section is the presentation sections. This is one of the sections I would say I think everyone can score maximum points here. The maximum points here are 6, and you would score 6 if you have given an oral presentation at a national or international medical meeting after being invited or selected to do so. So again, if I can go back down the lane, the UIP or the audit that I was talking about, if you have been invited to present it, as an oral presenter at any national or international meeting. If you have done that, so you're scoring both for a complete QIP that you have presented at a national international meeting in that section, and then you would score maximum in this section as well. So it's like 2 birds in a row. So I would say just push yourself to progress, and you would find that you would be scoring in other sections as well. The second best section is if you have done 1 or more poster presentations. Now, I know it's a bit difficult when getting invited into conferences to do an oral presentation. You would most often find, if you've been into a big conference, there are mostly registrars or consultants who are doing oral podium presentations. It's not easy to get one. Luckily, I had one, so that's fine. But most of the trainees that I've seen would score 5 out of 6 in this section. And that is for if you have 1 or more poster presentation. Getting poster presentations is easy. Just apply for it. You just have to stick a poster. Don't be nervous about it. Go well dressed on the day and just stand by your poster. People might come take interest in your poster. People might not come. It's an easy day. You just have to pay for the conference. You learn a lot. Someone might come ask you a question about your poster, and that's probably it. So you can easily score like 5 out of 6 in this one. And if you push yourself, maybe lucky with 6 out of 6. So again, a section in which you can do. And I mean, it's something when I'm saying national and international and presentations and projects. So earlier you asked me, people in other countries, what do you think they can do? They can easily do all of this stuff while being in their home country. If they're presented at their national, it's national. If they come here, now they're a UK graduate, they can even debate it as an international one. They can say, oh, well, presented this at a national meeting back at my home country, but now I'm a resident here. So would you count that as an international one? So, I mean, there are ways of getting around it. Being a medical student, yes, you can go to, it doesn't say whether you have presented it at an undergraduate conference or a postgraduate conference. It doesn't say those things. So if somebody has done all of these things in their final year medical school and is on it, they would count. So these are the things everyone can work, even if they're in medical students, provided, again, it depends on trainee to trainee, I would say. Some people, even from like their 3rd year medical school head on, they know this is the specialty I want to be in. And I admire those people because they're making the most out of their time and making their journey through ST3 very easy. Some people would be like me. They think they want to do something, then they go into house job and they would, oh, I think I want to do this thing, and then eventually they discover, oh, they need more time to decide what they actually want to do with their specialty. Some people even go through ST3 training and then decide, oh, this thing is not for me, let's go back. So I would say every individual is different, and that's completely okay. So if somebody know what specialty they want to be, they can just download these scoring systems and they can work through it. It's not impossible. Coming into the next section, that's for research. And research is maximum score is 7 here. So if somebody is a first author or a joint first author of 2 or more PubMed cited original research publications, they are scoring 7 marks on it. So let's take an average foundation trainee who have just been an average medical student. I mean, I don't see many people scoring the highest here. So it's again not something people say, oh, I need these many research and stuff like that. And that some people are more clinical training oriented, some people are more academic oriented. So the academic people, if you see, they would be an academic foundation program, there would be an academic core program, and then academic specialty program, and ultimately they want to do their PhD and become a professor. Not everyone of us is like that. Some people like more doing like clinical stuff rather than academic stuff. We all do academic stuff for these portfolio and stuff, and that's completely okay. But if you're not that kind of person, I would say don't take it hard on yourself. Yes, you should have research of experience of research, whether you're in your home country or you're here. It's a part of your progression and development, and you should definitely have it. But not, if you're not scoring maximum in this section, don't beat yourself. That's okay. People might be involved in research projects where they might be a first author in one project and PubMed cited. You can still score good points there, and there are six out of 7. 6 out of 7 is the second best mark. You're only losing 1 point here. So don't beat yourself. If you are a first author of one research, that is it. If you are a co-author, it might still, let me get this right. If you're a co-author of 2 or more research projects, you're still scoring 6. And then it comes down to if you're a co-author of 1 research publication, that's still 4 marks. 4 out of 6 is not bad. So people hustling about researches and everything, I mean, if you can do it, do it. Good, well done. Research takes a lot of time. It takes years and years to gather the data, come up with a good article, and then you send it to a lot of journals and everything, and it would get rejected 1,000 times. They want you to alter. There's a conflict of interest, and then at some point it gets published. It's years and years of work, I would say. So if you have been involved in some, I did some research during my final year medical school in electives. I had a lot of electives during my medical school, so I was a bit lucky. I was still scoring like 6 out of 7 in this section because I was first co-author on certain projects. But I have seen foundation, like again, average medical student, average foundation trainee, they wouldn't have much on this section. They might be scoring like 4 out of 6 or even like 2 out of 6, and that's completely okay. So there are certain sections in the portfolio, like the PhD first we talked about, having a PG cert in teaching, having the maximum amount of researches. These are things that you don't need to be anxious about. Sometimes you have to make peace with yourself, and then realistically seeing your goals where you can score maximum, because you might be thinking, oh, I need to do PhD, let's spend money and time there. So you're doing a PhD, what for? Just 4 marks, and then you don't have the time to do a QIP project and close it and present it, which is like an entire 11 marks. I mean, how? Why? I don't understand it. So I would say, look at time, look at money, how much score it's offering you. Is there anything in the portfolio that you can do in small amount of time? It's costing you nothing, and you come out with triple amount of marks than the other section. So just realistic goals here. That's what I want to say. The next section is, and this one is an interesting one. Again, it's on leadership and management. So leadership and management, the maximum score here is 8 marks, and it's if you have been on a national committee or something in a surgical society or any society, or in BMA. Now, I was very lucky with this one, so I was scoring 8, and that's probably because I had the what do you say, the scoring portfolio sheet. I mean, way before than I was applying. So I knew about this section, and I looked previously. So going back into my medical school and everything, I had leadership stuff. We had a student-run pharmacy. We had like a blood donor charity program and everything. But if I think on that, I was scoring at a regional level. So a regional level here, if I see would, how much marks would I score out of 8? Would be, well, I can easily say it would be 6 out of 8, which is not bad. But I think I knew about the scoring, so I could have easily expended 2 more marks here and scored full like 8 out of 8. Now the way I did it was, when I first came here, I mean, every IMG that comes here, people tell you, subscribe to BMA, subscribe to BMA, subscribe to BMA, it's 20 or so quid. And do it. So just as a part of the BMM membership, I just got this email saying something about a grassroots seminar. I don't know what a grassroots seminar is. I'm probably an introvert, shy, haven't been to much meetings at that point. I'm new in this country, 6 months down the lane. I'm like, what is this? And on the top of everything, it was Ramadan. So very interesting again. So I just went into the email, had to read about it. And so grassroots seminar is something that the BMA offers to any new doctor in the NHS. Now, any new doctor in the NHS has a very broad meaning. Some people would think, oh, they would be like very shy. They're like, oh, no, it's not for me. Probably they mean it for British graduates who have started their F1 or F2s. No, it is for everyone. It is for any IMG, no matter what your level is, and you are having your first job in the NHS. It's just a warm-up meeting to introduce you to BMA. You go there, spend a lovely free afternoon with them, and they sort of just do some debates on motions and stuff. And so I just went there. I was like, okay, fine, maybe I can make a few friends, like see what everything is about, what this BMA is about. So I went there for the grassroots evening seminar, and then the next day they had a free junior doctor conference. So the junior doctor conference there was, every year BMA has elections, and you would receive thousands of emails from like, elect this person, elect that person you have never met. They've just like passed a statement, and you look at the statement and you scroll down and you say, okay, which one do I? Sometimes I don't even vote. Like, I'm just like, I don't have time. Like, okay, just delete these emails and stuff. So when I went to the grassroots seminar, there was a free junior doctor conference the next day, and I was like, well, I went to Birmingham and staying with my relatives for the night. So I was like, yeah, why not come for like the junior doctor conference the next day? So I went there. And at the end of the whole conference, so there were people who were just debating and discussing all those types of matters in training or anything that the BMI does. At the end of the session, they were like, okay, well, we have a few leftover seats for elections. And I'm like, well, do I apply? Do I not apply? So the first round of applications, they were like, we have done our elections through these email and stuff and everything for like the executive committees and everything. And this person is the president, and this is this, and this is one, and person is this. I'm listening, like, being new in the country, I'm like, what is happening? Like, we only have like a Young Doctors Association back in Pakistan, which is also like a very broken down structure. I'm like, what is happening here? So then well, in my head, I already had this portfolio scoring at the back of my mind. So at this point, I'm thinking, well, I think I can score 2 more points here. So it was purely for the portfolio reasons, but then it's something I had already realized in 6 months in the NHS that I need to progress. I need to take on those leadership roles, managerial roles. I mean, for how long can you run from these things? You can't. They're going to chase you. So what I did was, they were like, we have leftover seats, and we would be very much happy for new NHS doctors to take on these roles, and we'll be fully supportive to them, even if they don't know anything about it. So they just advertised that during the meeting, and there was a sort of this BMA app where you just give a statement, which post are you applying to, and why do you think you should be elected for it. And I just wrote like a simple statement, a few lines, and then they just do an electronic polling. Some people are very much aiming for it. They would just go around lunchtime, meet people and say, okay, fine, I've made this statement, can you please vote for me, and this thing. I did nothing, like literally nothing. They had so many posts there. They just elected me as a junior doctor representative for the whole south of London for that year. So in my head, still thinking, I'm like, okay, South London, it's a regional thing. So what am I doing this for? I'm already scoring 6 there. Like, there's nothing to go ahead. So what happened after that is, being a junior doctor, what you do is you just liaise with your local negotiating committee in the hospital, see if they have any problems, and you just convey them to the higher BMA executive committee. Sometimes the LNC will just go ahead with it if they don't know we have like a junior doctor representative for the whole South London or any other region whatsoever. So there's usually an annual representative meeting for the BMA every year, and they would invite all of the people who have been elected on any kind of post with the BMA. You go there, it's a nice 4 to 5 days conference. I'm not sure if you have attended it or not. With a very good venue every year. 4 or 5 days conference, you go there, and then there's a whole book that they send you beforehand. You can go through motions. There are a lot of interesting motions that you can speak in favor for or against for. So you just go to the podium, just so one person will be speaking for the motion, another one against it, just debate. A very lovely day. And that's all you do. There's nothing much, to be honest. And if you have spent like 6 months or 1 year or anything with them, you can just email them and tell them, I've been elected on this post as a representative. Can you give me something for my portfolio? And they'll usually give you a lovely letter saying, Okay, so she has been on this post from this year to this year, and that was it. So I just expanded my score there and just scored 8 out of 8 for there. What for? Just by attending like a free seminar and then a free conference and then getting elected onto that. And then I go to the big ARM meeting, and there are like a lot of people, like a huge conference I've never seen. So it's good for experience. And that's free as well. I get my travel expenses reimbursed. They offer me free accommodation, although I was living very near, so I was traveling every day. That's another story. But I mean, there are things that people can do. There are a lot of societies, medicine societies, surgical societies. All you have to do is pick up a pen and paper, write down a statement, apply for those posts, be elected at it. They don't, it's not like being elected on a representative post is like you leaving your clinical work and going there. No, even most of the high executive committees in any surgical society, they would hardly have 4 to 5 meetings per year, and that's an exaggeration. Some of those have just like three meetings every year, and that's all you have to do. And they're all nice people, nobody's biting you. So I would say just go and apply to it. It's a wonderful experience for you. It is something, again, that I would say, I mean, my heart would break if somebody's not scoring in there. I know not everyone feels comfortable in a leadership role or anything, but I mean, if you have to do, you want to be in training, at a certain point, you have to do it. Everyone is a leader. I mean, take from a cardiac arrest call or a trauma call or a crash call. You may not be leading them, but you might be in other positions where they're delegating roles to you, where you are in itself a leader in yourself. At some point, at a certain level, you might end up being like the first responder to a trauma or a cardiac arrest call, and you have no choice. You have to do it. You're a clinician. So, I mean, if you have done something extra like this, it just boosts your confidence, and that's it. You wouldn't even realize how it's benefiting you, but it is grooming you and it is benefiting you. So something, again, I would emphasize on. I mean, I would say this is a section, push yourself. There's a minimum requirement for it. You have to be in that role for 6 months. You can't play around with the system just by going to like free meetings and stuff and then end up nothing. You have to contribute a little bit. So again, if it's a minimum requirement of 6 months scoring the highest marks, you need to pre-plan it a little bit, time for your application, and do it. So this is our last section now, I promise. I think I've exhausted you and myself as well. So the last section is commitment to specialty. This is the only section I would comment on that has changed since when I applied. So, I mean, it was a little bit freestyle when I applied, with only one permanent block. So the maximum marks you're scoring here is, hold on, I think I have to grab my calculator here. I'm so bad in maths now. So I think almost 16 marks that you can score here. And so they've inflated it a little bit. I think, if I'm not wrong and I remember correctly, it used to be 8 marks that you can score. Now it's 16, so they've inflated it a little bit. But the 8 marks were commitment to specialty. So commitment to specialty is a broad horizon, I would say. You can do a lot of stuff which can show what you have as commitment to your specialty. So I have my portfolio here. I don't remember what I did at that point, but I'm just going to flip into that section to tell you. Yeah. So it's almost, I'm splitting my portfolio in half. I'm going to show it just at the end of the session as well, so everyone knows it. So commitment to surgery. So what have I done here? I have attended conferences. I mean, this is not something extra I have done. Well, it is something extra I've done out of the way for, but it's all those QIP or presentations I've been through to. There's hardly any conference that I think, one of it that I did out of my probably love for it, that I spent extra amount of money on. The rest of them have been just for like doing those projects and presenting them. So by attending conferences, okay, that's 1 mark, good. Membership to surgical society. So I mean, you can subscribe to Royal Colleges of Surgeons. That's hardly 15 quid a year. And the other thing I did was Association of Surgeons in Training. So I have attended conference 1 mark. I have membership to a surgical society. So it shows my interest. That's another point. The other thing that I did was well, of course, in order to go through the whole application process, I had to go through at least some sort of interview course. So I did an interview course, which again, you can put down as like your commitment to special, because at the end of you're just preparing for it. So that's another mark, so 3 marks. And then I put down all my surgical rotations that I have done in my life since like after graduation. So I just said, okay, as a trusted SHO, I did this. As an F2, I did this. And like as an F1 equivalent back in my country, I even put one of the surgical rotations there. So just by doing surgical rotations, I'm showing my commitment. So what another mark? So that's 4 marks. The 5th is for, I put is for a taster week. So you can easily do a taster week if someone is in the UK. All you have to do is ask your clinical supervisor and ask them, I just need a week out from my regular work into another specialty. And the consultants know each other. They can literally speed dial or send an email. If they know which specialty. For example, if I am in like general surgery, or I want to do like a taster week in, let's say, neurosurgery or something, they would know who's in charge or the lead for that specialty. They can put you in contact, CC you in it, and say, okay, I have a prospective surgical trainee here who just want to go through a subspecialty to see if they click with it or not. And if that consultant is available, they're not on annual leave or study leave or anything, they would say, okay, fine, in my schedule looks like this is a good week for me. Do you think this person can come over and shadow us during that week? And then all you have to do is CC the rota coordinator in it. So if you are not on call or can get your on calls out of the way, you can easily go and do that one week taster week. So that's another brownie point for you. So what, 5 points here now? The other point that I put in was for any elective or observership that I did. So I had a few electives and observerships, whether that was back in my home country or I did one in 5th year where I came here to the UK. So that's another. So I would say I'm scoring 5 here now. Then I went to a surgical career fair. I mean, these are very common things that you need to think about. Surgical career fair, again, you would receive millions of emails for these things, where people would invite you, okay, we are having like a medical career fair, a surgical career fair, would you like to come? It's free. It's a good, nice evening. You go there, everyone talk about their subspecialty, and you see what fits you best. It's a good exposure as well. So 1 point for that. Then I did some free online e-learning modules. I mean, there's an ELFH website. You can do some with the BMA as well, BMJ, BMA as well. Again, so, I mean, and then what I did was I just put my e-portfolio in there. So my HORS portfolio from FY2, and I just, all the work-based assessments that I did during my surgical rotations, just the nice cases that I got nice feedback, not everything, yeah. Because it's already like a lot of portfolio and you just want it to be concise and to the point. So just a few cases from them, like, okay, so just my e-portfolio, so 1 score for that. And then I said something like presentations at morbidity and mortality meetings. So any rotation you're on, there should be M&M meetings. There are certain morbidities and mortalities. If you are attached to a firm or a consultant, they would likely ask you to prepare those cases. Now, it depends on the department you're working with. In some departments, it's like you prepare the presentation and then the registrar just take it on a platter and go and present those cases. I mean, if you think about it, and if it's something that's happening in your department, I mean, with my department, they were much more happy. The registrar would just sit like at the back as backbenchers, and they would like, okay, you have prepared it, so just go present it. And if that's not the case, you can politely ask your registrar, can I present it? I would be happy, and they would be more likely for you to present it. I mean, they're already a registrar, they have their NTN number, they don't want these things. So just go and present it. So I said, okay, I've done M&M presentations on this date, blah, blah, blah. I had evidence of all of these things in my portfolio. So I either asked the secretaries and told them, I presented these cases, can you give me a letter or something, and just CC the consultant as well so they know. And they would just give you a nice, good, fresh letter. So just presentations at your morbidity, mortality meetings. Another thing is attending your MDT meetings. Now, most of the MDT meetings in the department, usually they are, so I think the audience here would be very wide. If somebody is IMG and listening to me and don't know what an MDT meeting is, they're usually multidisciplinary meetings where you have consultants from cross specialties sitting there, senior nurses, even people from management side, where they discuss a lot of cases even from other hospitals, and it's mainly the registrar who's discussing the cases and everything, and somebody is just making notes of what the MDT outcome is. There's nothing much you are doing here as an F2 or F1. What you have to do is find out the dates for your MDT, go and sit in them. Once you have sit and listen to them, there's usually an attendance sheet, just sign it. Once you have signed it, I would say one thing, it's no point going back and forth and chasing these things retrospectively. Just take a picture of, once you have signed the attendance sheet and everyone has done it, just take a picture of it. So go to another MDT, go to another MDT. Once you have done, you don't need to attend like 10 or a million, just like 2, 3, it's enough. And in the specialty that you like, once you have attended and taken pictures, just make a PDF format of it, send it to the secretaries or the CC, just the lead consultant in it, and say, okay, I've attended these MDTs like out of my commitment for this specialty. Can I get a letter of my attendance for this thing? They would usually send you a very nice letter, and then you can stick it in your portfolio and say, okay, I've presented at M&M meetings. These are free things that you can do. And you can all do it during your work. You don't have to spend a penny. Yeah, maybe buy a nice hot chocolate and coffee and go sit in those MDTs so you don't fall asleep. Most of the things would be not, as per your competencies anyway. So, now I have narrated what, like 10 things. And at my time, you could have easily, if you have like put 8 things and you can justify it with evidence, you can score 8 out of 8 in here, which is fine. So I would say there are a lot of things you can do in this way. It's changed a little bit here now. So I had something here as surgical courses put in, and this is something that you need to book in advance because the dates are not available, and of course you have to pay for it. This is not like a free thing. So the 2 basic courses for core surgical training that I would say, and they would expect you to have it done, would be your advanced trauma life support course, that's ATLS, and your basic surgical skills course, BSS, and both of them can be done with Royal College of Surgeons. So the maximum amount of courses that they require from you are 2. And if you have 2 courses, then each of the courses score for 2 points, which makes it about 4 points. So that's something that they have fixed now. And it was fixed in probably one of the things that was mandatory in commitment to surgery that I had to do. I can't get away with it. So I would say, apart from that, those 2 points out of 8, the rest of the 6 points were an open field to me at my time. And I've already, put a lot of things like 10, 11, even if the interviewer doesn't like 1 or 2 things, I would be like, oh, well, I have like a whole lot of things like lined up here. How far can you say I don't like 4, 5, 6? Like I have like 12 things here. So easily justifiable and easily scoreable. Looking from this year, so we have already talked about the courses. So if you have 2 courses, you're scoring 4 here. It used to be like 1 for each course, but now it's 4 now, which is fine. They've made it a little bit fixed, so it looks like you can't put like these things, but if at all in future it changes again to what it was, I've just given you an idea of what you can do. Then the other thing in this section in commitment is completion of a surgical taster week, and it's giving you 3 marks. Although it wasn't fixed at the time I applied, I have still done a taster course, so it's nothing out of the blue they're asking you, it's something expected. So go for that taster week. You can easily score 3 marks. What was I scoring on a taster week? 1 mark? You're scoring 3 marks here. Just do it. Another thing is a surgical elective. Most of the people would have done it in their medical school. Again, what was I scoring for it? 1 mark. And I had to do like a whole lot of things to say I'm scoring. Like I had to show like more than 8 things to say I have done like 8 things. No, they have fixed it for you. Doing an elective, you're scoring 3 marks there. it's an easy go. So although it looks like they're fixed and you have to do it, it's not something that people can't do. Elective, test a week, 2 courses, it's okay. And I mean, another thing is, they've put something like surgical logbook. Now, I had put my, I think I forgot it. I put my surgical logbook in this section as well as commitment to specialty. They have fixed it to, you should have at least 15 cases on your surgical logbook. Now, 15 cases doesn't mean you have to be at a consultant level competent and do like appendicectomy, cut and shut and everything. No, it's not like that. It's just going into theater, scrubbing in, assisting. If you have likely, I mean, if you're on a surgical rotation, you will easily get more than 15 cases to scrub in. It's not that hard to ask. So if you have 15 cases or so, I mean, you can just compile your logbook without any patient identifiable information. I know someone who went into core surgical training interview and just with those brilliant patient date of birth and hospital numbers, and they were reported to GMC. So I would say, be very, you have to anonymize everything. Fine, if you want to sign it from a consultant, just go with the logbook which have patient identifiable data in case they want to cross-check. Most of the consultants here are very sweet. They, I mean, they completely trust you. If you have done the rotation with them, they're happy with your work, you can just sign and anonymize one. What I usually do is I make a logbook with the patient number in it, and I just keep a copy to myself for my record. In case anything happens in future, I have to come back to that case, so I know where to go. In the portfolio, everything is anonymized. You're not supposed to put patient numbers, date of birth. I don't even put age or anything. So just the procedure date, when you did the procedure, what procedure was it, whether you were assisting in it or whatever it is, and that's it. So just make a small logbook on a white A4 paper and put your hospital logo on it and sign it from them, and that's it. So that's something that they have fixed. And then another thing that they have changed is, so in commitment to surgery, you could have, when I applied, we could have put like, if the maximum was, if you have taken your MRCS exams. So now I'm saying taken MRCS exam, it means I have either applied for MRCS Part A, or I have applied for MRCS Part A, sat in it, and then not cleared it or failed it. And I would still score 1 mark for it at my time. It looks like they have changed this now. So they've, if that's the criteria, there's still 1 mark for it, but then they've inflated it to, I've sat and passed MRCS Part A exam. So I've sat in and I've passed MRCS Part A exam, and then you can score 3 marks for it, but fine. It's still not end of the day. You're just losing 2 marks there. It's fine. Most of the people, if they know they want surgical specialty, they would take their exams during even their foundation program. Some people, I mean, for me, I have just cleared my MRCS Part A exam in the last September attempt. And I just took it and I sat for it. Before that, I hadn't even thought about it. Why? For me, because I was on an IMG, the rules were changing and everything. Taking an exam, you have to study hard for it for 3 to 4 months. You have to pay a hefty fees, and then you have to clear it. For myself, I know, I mean, any exam, if I put my mind to it, I pay for it. I just go, I take my exam and I clear it, and that's come it. With me, it has never happened. I'm not praising myself for anything, but I'm probably one of those candidates where it doesn't happen with me very much often that I go fail the exam, go fail the exam, go fail the exam. No, I know when I pay for it, I have to clear it, I have to do it, I go sit, pass, just that, done. So it's just that I know myself. I haven't, like, MRCS Part A wasn't anything for me that I have gone through like 3-4 times, haven't cleared it and just did it now during my surgical training. No, the thing that I was thinking about, what if at all I don't end up in core surgical training? I mean, where does this sit? MRCS Part A. Second, it wasn't a fixed criteria like this. If it was a fixed criteria like this, trust me, I would have it in my portfolio at that point. So again, it's not end of the day. Many people take their exams. I know CT2s, CT3, they're still stuck in exams. They're not easy exams, that's fine. So, I mean, you may find a brilliant person who has done their MRCS Part A before CT1. but that's not end of the day. And it's for sure not an eligibility criteria. It's not like you can't apply for CST if you don't have MRCS. Like for ST3, yes, it's a requirement. It's an entry requirement. You have to have full MRCS before even you can make an application for ST3. For CT1, it's not an entry criteria. Yes, it is an exit criteria. You have to finish your MRCS to get your core surgical competencies, but it's not an entry criteria. So I would say, again, it's an advantage to yourself. So I know they have fixed it, but if someone doesn't have it and the application is approaching, I would say don't be anxious about it. If someone still has a year or so, I mean, at some point you have to do it anyway. RLMT has been exempt, you have good bright chances, so I would say just take it. It's much better to take it before than leave it to the end. And one thing that I can't see in this, or probably maybe in the fine print, is we had 3 extra marks for just having this portfolio, like a well-organized to-the-point portfolio. You would get additional 3 marks. So you would be surprised candidates do come into the exam and they have like very disorganized portfolios. I mean, you are a consultant, you might have seen it now, but there are candidates. So again, those were brownie 3 extra points. Maybe in the fine print, there is someone, if somebody is watching and they've gone A to Z on this paper, it's a 14-page PDF file, and there are still 3 points, just make a comment on it and say, yes, there are still these 3 points. But I mean, I can't say, it used to be like another table saying 3 marks for like a good organized portfolio. I can't see any table anymore here. But do go for like, make your portfolio precise, to the point. This is evidence you have done this, this is evidence you have done this, this evidence. And that's probably it for the portfolio. So
thank you for sharing your experience and advice around portfolio. What about the 2 books you said you would recommend? 2 books that people can read if they are going for surgical interviews?
Let me get the name here. So I'm going to open it and show it to you guys by the cover. So one of the, I'm not sure if anyone can see it.
Yeah, I can see that, yeah.
It says core surgical training interview. Hold on, I'll be able to maximize it. Yeah, so it's this book with, it says core surgical interview book.
Yeah.
And it's been written by previous, I mean, one of the guys who's an editor on this book was a professor in one of our HPB department. I was working in London. So, I mean, this is a very nice book, and it is very relevant to your interview and the structure of your interview, the way you answer your questions and everything. I would say just read this book. If not, I mean, I would say not once, read it twice. The other book is, I think every IMG knows about this book, and whether you go for medicine or, let me see if I can spend it. Oh no, I can't. Anyway, it's I think it's this book with a lot of
medical interview, yeah,
everything. Yeah, so it's a medical interview, ISC medical book, and I think every IMG who's in the UK would have read this, either for, I mean, even for applying for your trust grade job. I would say go through this book. So with regards to core surgical training, I mean, I would say you don't need to read the entire book.
Yeah.
Just the leadership and management bits, you might get a little bit more idea of, there is a small surgical scenario section, not big, so just go through that. but it's still something that you can benefit from. But the first book that I said is, I would say definitely go through it, if not once, twice. Again, I mean, it's just reading books and everything. I mean, it wouldn't do much benefit. I would say get along with other trainees who are slightly senior than you, with your registrars, consultants. You need to have mock interviews. Even if you go to an interview course, that's not enough. Sometimes it's a lot of information in a small space of time. And most of the times when you come back, you just lose your sleep and think about it, what's happened there. So you just need daily practice with everyone, and that's, I mean, that's probably it. So a lot of practice, face to face, to get the fear of the interview out of your brain and just get more fluent on it.
Thank you.
About the portfolio, just one last thing. So this is how my portfolio looks. I mean, don't be scared by the width or anything of it. So this is a sticker they would give you on the day of the interview, which circuit you are on. I've just put nothing, just like my name on it, just reasonably not expensive. Now you look at the section and the subsections here. This is how much organized you need to be. So put stickers in it, QIP project, this 1, 2, 3, 4, put a very nice sheet at the beginning of your portfolio, say section 1 is this, section 2 is this, page number this, page number that. Make commitment to specialty. You can see this much thickness is just commitment to specialty. It's all crappy stuff, but you need to make subsections in it. So I would say organize. Now, organizing something like this, you can't do it a day before your interview.
Okay.
I would say, so starting on from even today, once you have submitted your applications, you should, I mean, anyone who is applying now, if you're listening to me, you should have started compiling your portfolio 1 month before from now. Yeah. Now, don't get panicked if somebody else hasn't already. There's still time. What I mean to say is, even when I was doing all of these things, like once I'm done with one rotation or getting out of a hospital, I used to take like all my evidence and letters from everyone. You need to do it in time. Sometimes it's very hard to go back retrospectively, bring back memories of you working with someone on a certain project, and then and just find a good opportunity and a window. If they're happy with you, just get that letter. And compiling all these letters and everything, it's not easy. You will go hundreds of times through the portfolio and still forget something. So in order for it to be organized and everything, just crack on way before. It's not something you should be leaving to the end. By the time, I would say, so when I applied, when December was starting, my portfolio was ready. There was maybe a thing or two that I was waiting for, or maybe just putting the stickers in so they look nice and fresh. Apart from that, I had my portfolio ready at that time. From December onwards, what I was doing, I had already read these interview books. What I was doing is just either revising it or having face-to-face group practices in my hospital with my colleagues, whether even people who are applying at the same time with me. So this is again another thing that I would want to address. What people most often do is, if they are applying for the same application, they would pit against each other. Now, this is not something you want to do. If you have found people who are applying, you just need to be like building blocks to each other. You are a group of people within the same hospital who are competing against the rest of the country candidates. So take maximum advantage of it. Practice with each other, work with each other. It's all teamwork. Sometimes maybe they can organize consultants or interviewers who would be happy to interview. Sometimes you can do it. Just take it to your advantage, and a lot of face-to-face practice. It all needs a bit of pre-planning and everything. I know it's a lot of time and effort. I'm not scaring anyone. If I have anyone, my apologies, but it's not something that's not possible. I mean, everyone can do. If I've done it, I think everyone can do it. To be fair. So I'm not sure if I've missed anything. Completely exhausted.
I think that was a good. I think it was a good 2 hours interview. I think you have covered a lot of things. Thank you very much for that. I think if there are questions, I think people can direct towards you, or I'll share the link of your blog so people
Yeah.
can directly ask, follow that blog and ask you the questions if they are confused about.
Yeah, might be I've missed a lot of points. I mean, every individual circumstances are very different to mine. I know when I came to this country, I've been like a bit more. Sometimes people have to tell me like, take a beat, like just sit down. And I mean, there might be people who are other. I know I appreciate a lot of our colleagues who have like a lot of experience back in their home country. Coming here, starting back from scratch as an SHO or registrar might not be the ideal option to them or anything. And everyone's circumstances is different. Like people approach me and say, hey, I'm halfway through my training back in my home country. Can I get into CST? I mean, I usually don't have, sometimes I don't have time, I'm busy or anything, but whenever I get back to them, I would rather be like sweet but blunt to them and tell them, see, this is the reality, this is this. It's not something like, oh, I'm a woman in surgery or something and I don't want you to come to this country or do this and that. It's just, I've seen it. I know you're much more experienced. You might benefit from coming here later on in your career once you're done finishing training there, because there's no way if you have more than 18 months of experience and nobody would allow you for CST. You can surely come and apply for ST3, but again, it's up to you. If you've already finished training back there, you might benefit from doing like a 2 or 3 year fellowship here. And then maybe just completing Article 14 or Caesar pathway and staying as a consultant, or if that individual is oriented going back to home country at some point, just do a fellowship and go back to their home country or something like that. So individual's experience, age since graduation, everything is different. So I mean, for me, I would be an ideal person guiding someone who is in their 4th year or final year medical school and is thinking of coming here, or is in their F1 year currently, even in F2 year. For people who are currently applying or going through the application process, I'm a bit too late in explaining all of these things. But again, I mean, I can only do stuff when I have time or I'm in like the proper frame of mind rather than rushing through. And this whole 2-hour session, me even showing you the portfolio and everything, is because at least I want to get it out there, because each time, every weekend, I think I need to sit down and contribute to the community and write something down.
I think that
something comes up. Like, editing is not easy. There are lots of stuff that we need to sort out in our current job, even in home life and stuff like that. So I haven't really, I may write a blog at some point, but I hope, I mean, I've just rushed through things so everyone have an idea.
Okay.
And that's it. I mean, I'm very much happy to help anyone who wants to approach me or anything through my blog. They can leave a comment there. There's a full comment section that I keep checking week to week. That's probably the only thing I'm doing punctual in it. Or, I mean, whichever platform they want to reach me, they can reach me. I can go through it. I'm more than happy to, if somebody's portfolio is ready, they're applying now and going to interview, and they have their whole portfolio in with evidence and everything. If they want me to go through it, I'm happy to go through it. I mean, I know COVID is not easy. I can do Zoom sessions and stuff like that. Don't even mind face-to-face. I mean, depends on the person again, COVID-wise. But I mean, I'm approachable. It's not a scarecrow or anything. So
thank you.
Yeah.
Thank you very much for your time and all this effort.